Professor, you're on mute.
Oh, okay, thank you. All right, don't worry, it allowed me to restart. Okay, so we are recording. This is chapter 62, page 1250. This is still a fluid and electrolyte problem, still falling under endocrine. We have concluded the 3 acute complications of diabetes. Let's look at now 2 opposite problems resulting from a posterior pituitary gland problem. So this one specifically affects antidiuretic hormone. Unlike aldosterone, wherein it affects sodium and water directly, meaning as the adrenal glands release aldosterone, usually in response to low blood volume or high plasma osmolarity, meaning the patient is dehydrated. So aldosterone is secreted automatically, and that will lead to increasing preload, which is reabsorbing water and sodium at the same time, increasing blood volume, increasing preload, increasing blood pressure as a result. So here we have various reasons, usually from a either head injury or a patient has a brain tumor. A patient can develop diabetes insipidus or syndrome of antidiuretic hormone, which is the opposite. This patient here presents with severe dehydration with one exception though in the findings, because usually what you learned in 3rd semester, what does a dehydrated patient look like? Specifically to the, don't think about diabetes insipidus. Just look at, let's say, Michael Kahn is dehydrated. What will his urine output be if he is dehydrated?
It's less than 30 ml per hour.
Exactly. And so therefore, since he's not making enough urine, what will his urine look like?
Very concentrated.
Very concentrated. Very good. So under normal circumstances, a dehydrated person would present like Michael Kahn did. So his urine output will be low and his urine osmolarity is very high. It's very concentrated. Specific gravity will also be very high, correct? Yes. Now in diabetes insipidus, that's the only exception. This patient is still dehydrated, but not for the reason that it's usually caused by. So this one, the patient with diabetes insipidus is urinating like crazy, up to 4 liters or more per day of urine output instead of the usual 1500 ml average urine output. This patient's peeing like a racehorse. Okay. As a result, though, so what will their urine output be?
More than 600 cc.
Oh, so they have polyuria. So therefore, if you're in polyuria, what will be the concentration of your urine?
It's very diluted.
Very diluted. So what will be the specific gravity?
It's very low.
Very low. So this is the only exception here. So if you're speaking of a trivia, when you're asked what is the only dehydration state wherein you have a high urine output, but yet the urine specific gravity is low and the urine osmolarity is also low, this is the answer. So the problem here is because the patient lacks a hormone, they lack the production of antidiuretic hormone. For reasons I already mentioned, usually it's a brain trauma, brain injury, or a brain tumor reason that they have a deficiency of antidiuretic hormone production. So here, antidiuretic hormone, though, unlike aldosterone, wherein it affects sodium directly, antidiuretic hormone only affects water. So as stated here, the collecting ducts in the urine do not reabsorb water. However, even though sodium is not mentioned here, it will still indirectly affect sodium level. The reason is, what will be the concentration of the blood now if they're losing so much water because their kidneys are not reabsorbing water?
Blood is concentrated, thick.
Okay.
Yes.
So
Pumpy.
there will be a resulting hypernatremia. However, the reason is due to hemoconcentration, meaning the sodium level rose not because they're retaining sodium, because they're losing water. Does that make sense?
Yes.
But we will still treat the resulting hypernatremia nonetheless because the patient will be symptomatic. Here's a action alert here. I actually had a let's call it a crush, a high school crush, who developed DI. So when I saw her in her college days, one time, she was still in DI. She wasn't fully treated yet. So she would look really haggard. Her skin is so dry, lips are cracking. Her skin obviously is, you could cut her skin with your fingernails. She was that dry. And she would just carry around big jugs of water, not water bottles anymore. I'm talking about like 2 gallon or a big water bottle. There are two types of diabetes insipidus. We have primary and secondary. The difference is just the cause, but doesn't really matter because the symptoms will be the same. So there's really no need to distinguish between primary and neurogenic or nephrogenic diabetes insipidus. Okay, that's nice to know because it doesn't really affect the signs and symptoms. However, it may be a question on the NCLEX, not on mine though, asking you what are causes of primary, what are causes of secondary, or what are causes of nephrogenic diabetes insipidus. But again, not for mine though. So I already mentioned these are the usual causes, usually involving disorders of the brain. There is also a drug-related diabetes insipidus. Lithium is known to cause it. All right, so no need to belabor chart 62-5. These are nothing new. The patient in diabetes insipidus looks very dehydrated, and these are no different from what you learned in chapter 11. So a patient who is dehydrated is hypotensive. That triggers the sympathetic response, causing increased heart rate. But obviously, that won't be enough to raise blood pressure. And so because of loss of fluid volume, low preload, there will be weak peripheral pulses, hemoconcentration, as I already mentioned. However, this is the only thing different. In chapter 11, this one shows decreased urine output and increased specific gravity. So this is again the only exception though from chapter 11. That's the only thing different in diabetes insipidus. Question so far?
Professor, can you just remind me, you said urine output would be high, specific gravity low, and osmolarity low as well?
Urine osmolarity.
Urine osmolarity, gotcha.
Yeah, right here in the kidneys. Again, a reminder, okay, so if you review chapter 11, that's the opposite because the causes in chapter 11, the mention there is actual fluid loss, no normal fluid loss, not a antidiuretic hormone deficiency. So here in diabetes insipidus, the main cause of the dehydration is the deficiency of the antidiuretic hormone. That's why the urine output and the specific gravity is different from any other dehydrated patient. Interventions. So they lack antidiuretic hormone, so very simple, we replace it. The patient will be carrying around desmopressin tablets. They carry it in their purse, So there are also different forms now. We have sublingual melt for faster release, or even in a spray. As stated here, there's no fixed dosing. The frequency of the dosing really depends. So if the patient loses more water than usual, then they can increase the dose if needed. Here these are some recommendations. They will be taught if their condition is severe, then there will be 1 to 2 meter doses 2 or 3 times a day. So again, there's no fixed doses. They can adjust it depending on the fluid loss that they are having. Of course, if they're already in shock, which they will be admitted to the hospital, then the ADH, the desmopressin, will now be given parenterally. Here's a warning that the parenteral form of the desmopressin is 10 times more potent than the oral form. Non-pharmacologic interventions, of course, we urge the patient to replace fluids by mouth if possible. How they know how much is equal to the urine output. You can be literal here, meaning you can tell them to measure the urine output if possible, but that wouldn't be practical, right? Who would want to be carrying around a urinal? Or a female, for instance? How do you teach a female to carry around a urinal when they're out? At home, maybe that's possible, but if they're out and about, that might not be possible. But these patients will learn to know themselves, just like you guys would. You can estimate the amount of urine you pee if it becomes regular. And here's a practical teaching for the patient. So if they feel thirsty and they see still an increased urine output, then they need another dose. The most accurate way or indicator of fluid balance is, of course, the weight. You learned this in third semester. 1 kilogram is equal to 1 liter. And of course, 1 pound would be equal to 500 milliliters. It's also easy to experience water toxicity because of the condition, so you may not be able to estimate. So teach the patient the signs of water toxicity, which are persistent headache, acute confusion, nausea, vomiting. Because you can tend to overdo it. It may be possible. Here's your teaching. This would be, no, that's a test question. Oh yeah, this is a teaching. So this is for discharge teaching.
Professor,
Yes.
one quick question. So suppose if they have a large amount of urine, so would that be that if they go outside, so they can wear like a dependent or something like that, or if like I don't know how much on the
Diapers? Like diapers?
Yes.
It's up to the patient, but it's not, meaning they do what they need to do, but it's not really recommended because it doesn't mean that they're incontinent.
Oh, okay.
But if it makes their life better, yeah, have at it. I mean, it's a free country. But there is it's not known that this will cause incontinence.
Yes. Oh, okay. So is there any roughly estimate that how much they will pee at one time, or is
Probably easily 600 at a time. It depends on how long they hold the bladder.
Okay. All right. Thank you.
It really varies. Like you, for instance, you can hold up to a liter if you want. But remember, the normal bladder, the threshold is around 200. When you reach 200, you already feel the urge to pee. So it's really up to the patient how long they'll hold it. To answer that question, I don't know.
Thank you. That's okay. Yeah, thank you.
It really depends on when the patient wants to pee. But the total, yeah, we know the total. So they can have at least 4 liters of urine output per day.
Okay. Thank you.
Any question on diabetes insipidus? All right, let's go straight to the other problem. So this is the complete opposite. So in DI, we didn't have enough antidiuretic hormone. Here, SIADH, we had too much. The causes are similar. It's still caused by traumatic injury, traumatic brain injury, typically in stroke patients. This is very common in stroke patients. You have a list here, 62-1. Here's stroke. In the CNS disorders. It's also found in other cancerous or non-cancerous, usually pulmonary conditions. And again, a list of drugs here have been associated with SIADH. So if in DI we have not enough, here we have so much. So here, instead of having a urine output of at least 1500 ml per day, which is normal, these patients won't have that. They will be oliguric, so they will have therefore about 400 mLs for the whole day. So this patient obviously is in fluid overload, but again, just like DI, if you compare this to the fluid overload patient in chapter 11, there is an exception again on the urine output. So let me ask you, in the patient in chapter 11, if you're in fluid overload, what will happen to your urine output normally? Let's say you went out drinking or, partying, you had a lot to drink, both beverages or including alcoholic beverages. What will happen to your urine output?
Increase.
Increase, right? And then what will happen to the concentration of that urine output?
It'll be decreased.
Decrease. So therefore, specific gravity will
Decrease.
decrease. Very good. That's not what's happening in diabetes, in SIADH. So just like in DI, this is where the exception comes in. Because the patient has too much antidiuretic hormone, they are not making urine. They keep reabsorbing water at the kidney tubules. So as a result, they have fluid overload, less urine output. They are oliguric. So therefore, what happens to their urine output?
Less.
Concentration, therefore.
Yeah.
What happens to the urine concentration?
It's high.
And specific gravity will?
Specific gravity will be high too.
Okay, very good. But now let's look at the serum now. In the plasma, because now you keep reabsorbing water, what happens to your fluid volume, to your blood volume?
It's high.
Increase.
It's
increase.
high. So what happens to the blood when I draw blood from you? What will your blood look like? Is it going to be concentrated like in diabetes insipidus?
No, it's thin.
It's very diluted.
Light.
Right. It's going to be diluted. So it result in a delusional hyponatremia. So even though, again, antidiuretic hormone does not affect sodium directly, indirectly because of the retention of water here, there is now a delusional hyponatremia, which will cause symptoms again.
So it will be like hyponatremia, right?
Yes, because there's too much water compared to blood volume. So it will lower everything actually. So HNH will drop, sodium levels will also drop.
Okay.
Here are your causes again, which was already mentioned in the table. Let's go now to signs and symptoms. So the majority will be signs of fluid overload along with signs and symptoms of hyponatremia. Here are your signs of hyponatremia in this paragraph. For this exam, I will only pick the ones that I mentioned here. I won't go back to chapter 11.
Thank you.
Okay, now for fluid overload, normally in other patients who have fluid overload, there will be edema, correct?
Yes, edema.
Earlier we saw that in any other patient who has fluid overload, there will be edema, not in SIADH. This is the explanation here. So even though patient is in fluid overload, because only free water is retained, does not affect sodium. There is no dependent edema. However, there's a big however. Can this patient develop heart failure?
Yeah, from
Yes.
Yes,
For
due
sure.
to the fluid overload. If this
Mhm.
patient develops heart failure, then you will see dependent edema. But that dependent edema though is not because of SIDH, it's now because of heart failure.
Yeah.
Does that make sense?
Yes.
Okay. So let's go to interventions. What do we do for this patient? So if we gave a lot of fluid replacement in diabetes insipidus, what do we do for this patient in SIDH?
Diuretics.
Right, fluid restriction and diuretics. So we have here fluid restriction. Look at this. Usually we hold it for heart failure, for instance, we restrict it to 1,000 a liter a day. This one may be as low as 500, depending on the urine output. So we will only give them water. We will only allow water equal to how much they urinated in the last 24 hours. Give or take a few, because we do have insensible fluid loss, meaning urination is not the only way we lose water. We lose water from talking. Speaking of which, I need a water break.
Mhm.
All right, so just like in DI, you check fluid status constantly through your blood pressure, your heart rate, urine output, and especially the weight again. So same thing, I already mentioned this earlier, 1 kilogram, 1 liter, 1 pound, 500 milliliters. There are drugs involved if, let's say, um, the patient has severe hyponatremia now, because that will now look at the signs and symptoms again. Hyponatremia, the patient could go into seizures now and become comatose. So if that happens, we have to correct the hyponatremia quickly. The only approved drugs to do that are the Vaptans. We have two, tolvaptan and conivaptan. However, you have a drug alert here. They can only be given in a hospital setting because they have a danger of causing hypernatremia, which is now the other problem. So we can't, there's no such, there's no PO tolvaptan or conivaptan. They're only available IV. And here they mentioned the black box warning for exactly for that reason, so they can't be given outside the hospital. Somebody mentioned the diuretics, so here it is. So in addition to fluid restriction, we give them diuretics. However, there's a warning here. Um, right here. So you use diuretics. Remember that diuretics can also lead to sodium loss. So that's just a warning there. So when you do give diuretics, make sure the sodium levels aren't very low. In that case, so let's say the sodium level is still low. Can you give diuretics?
No.
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 So the other option is to give hypertonic saline,
Oh,
3% sodium chloride. However, again, what's a consequence if you give hypertonic saline? So this is a very osmotic solution. What will happen to fluid volume if you give 3% sodium or any hypertonic solution?
Fluid overload, possibly.
All right, so this will cause further movement of water from the cells into the vascular compartment, exacerbating your fluid overload. So either way, this patient cannot be treated easily.
yeah.
So you give diuretics, you still have to watch sodium. You give this, then you watch fluid overload. Okay, so you can't you can't say this patient is on a typical med-surg floor. All right, so these at least they'll be on telemetry because you have severe hyponatremia, or even in ICU if they develop heart failure. You know about the signs of fluid overload, which are consistent also with heart failure, including pulmonary congestion.
Black holes in the lungs.
Right. As pulmonary edema can result, you have left side heart failure. Because they're at risk for seizures, so you institute seizure precautions. Speaking of which, what exactly do we do if the doctor orders institute seizure precautions? What do you prepare?
The aspiration
Put by the bedside.
at the bedside.
What do we put at the bedside?
Those seizure
The
pads.
airway.
What are seizures? What is that?
Padding for the bed rails.
Okay, you pad the bed rails. What
Pad,
else?
yeah, the seizure pad that you put by the bed rails.
Make sure you have a suction unit.
Suction unit, yeah, aspiration.
Suction and
Oxygen.
oxygen. Very good.
Oxygen.
What about padded tongue blades?
Yeah.
No, tongue plates, we don't use it.
No.
Who said yeah?
No.
You guys did this last semester, right? In
Yeah.
Table 1?
Mhm.
Are we still using, or are we shoving anything down a seizing patient's mouth?
No.
No, you don't put anything in there.
Mhm.
Another thing is you, in case it comes out on a select all that apply question, just saying, do you need an IV access?
Yes.
Okay, because once the patient's already seizing, can you put in an IV?
No.
Good luck putting an IV when they're already in tonic-clonic.
Mm-hmm.
All right, and that's it. Very short. We did it in, I don't know, 30 minutes. You want a break or you want me to continue?
I need a break.
All right.
Yeah, break.
All right, let's adrenal problems. So we have two adrenal problems. One is too much, one is too low. This is the good part about endocrine disorders. You only have two problems. Either you have too much of a hormone or not enough of a hormone. Just don't confuse the signs and symptoms and the treatment, because that's usually what happens on the exam. Because there'll be questions on the diagnostic findings, like what the blood will look like, what the labs look like. Those are where you, well, most students anyway, mess up on. Okay, so there are three hormones typically produced by the adrenal glands. We have three S's. We have the salt, sugar, and sex hormones. Of the three, only two are life-threatening. The sex hormones can be serious, relatively serious in a female patient, because the patient will look unsightly. Okay, it will cause, I don't want to say ugly, but let's just say the female patient won't like it. Okay. So we have salt, sugar, and sex hormones. So the salt hormone obviously is the aldosterone, or that's what we call the mineralocorticoid. Then we have the sugar hormone, which is cortisol, and then the sex hormones are your androgens. Female would be progesterone, estrogen, and then the male. However, no, the male won't be affected here, because unlike the females, wherein your pituitary gland can affect the adrenal gland, which affects your sex hormones. The male sex hormones are only in the testicles, so we don't have any adrenal control of the male of the sex hormones in the male patient. So there won't be a problem in the male. I'll just go down the chapter. It begins with the deficiency first. The deficiency is known as Addison's disease. However, both conditions can have a life-threatening emergency, meaning they will have acute episodes which can become life-threatening, meaning there will be triggers wherein the patient will have a severe deficiency of those three hormones. Again, the most concerning for us are the salt and the sugar hormones, because those we need, like for aldosterone, for instance, we need that in order to maintain blood pressure, blood volume. Cortisol, we need that for blood glucose levels. Okay, so those can be life-threatening. The management is discussed after the table. So here, the chapter starts first with the adrenal crisis. So let's begin with that. And then it will follow with the day-to-day management of Addison's disease. So let's go straight to the emergency. So there will be triggers. The triggers usually is stress. The patient is under stress, and for you, what would be stressful for you?
Exams.
All right. It can trigger a crisis. What else?
An accident.
All right. Trauma. Surgery is
a home invasion.
okay. Yeah. So all of those can trigger a crisis. Right. Most triggers are right here. So in response to a stressful event, surgery, trauma, severe infection. So therefore, can a patient with Addison's disease undergoing surgery develop a crisis?
Yes.
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 Admitted, who has Addison's disease, who is admitted for sepsis, can they go into a crisis?
Yes.
Right, so they could die during hospitalization. So this is now falling on you. So the patient's admitted, you see Addison's disease on the diagnosis, they're taking hormones because that's how we treat them every day. They have to take the hormones because they have a deficiency. So of course you replace the hormone. So they don't have enough mineralocorticoids, so you replace it. You give them Solucortef. They don't have enough cortisol, then you give them steroids, okay, corticosteroids. So here is the emergency. This is how we manage it, 62-6. So this has something to do with the two hormones. So your aldosterone is low. It's actually explained right here. So if you read this section right here, let's start with aldosterone. So if aldosterone is low, and the function of aldosterone is to reabsorb sodium in water, if you don't have enough aldosterone, what happens to your blood pressure and your blood volume?
It goes down.
Decreases.
That would explain the first problem here, which is shock. The patient goes into shock, so that's what we manage here. Although this type heading here doesn't say shock, but this is basically it. Look at the interventions. We give them a bolus, D5. So this solution here, either saline or 5% dextrose. I would go for the 5% dextrose because this will hit two birds in one stone. However, if the blood pressure is severely low, though, you need an isotonic solution. So in that case, NS is preferred. And here's the Solucortef. You need this in order to replace your aldosterone. So this will be given several times. You give it as a bolus and then a continuous infusion, and then another IM dose twice a day. Okay, and then this one, because the patient is it's a stressful event, right? So therefore, there will be severely increased gastric acid secretion, which can cause peptic ulcers. So we need to give them H2 receptor blockers. So that's standard for any stressful event. So that was for aldosterone. Let's go to cortisol. So here in cortisol, right here, decreased cortisol. So your patient goes into hypoglycemia. So this is a non-food intake or non-insulin related cause of hypoglycemia, meaning the patient here doesn't have to be diabetic. In fact, yeah, this can happen to non-diabetics. So this is an instance wherein a non-diabetic will experience hypoglycemia because you have zero or very little cortisol. So you're unable to increase blood glucose. So that's why the second management here is, no, the third, they put it third, hypoglycemia management. And we just concluded hypoglycemia with the quiz today. So these are your options. Okay, you're expert on that already. So the third one is still related to aldosterone. Now, since we lose sodium, right? Because the aldosterone level is low. So we lose sodium, we lose water. That's why the blood pressure drops and we could go into shock. While we lose sodium, what happens to potassium?
It increases.
Okay, so in response to the same thing here, when you lose sodium, potassium is retained. So the third problem is hyperkalemia.
Hyperkalemia.
Okay, and then we already discussed this in chapter 11 in third semester. There are different ways to lose potassium. So the fastest way is to shift it because excreting potassium is difficult because remember, this patient already has dehydration, hypotension. So can the patient experience kidney injury here, which you learned last semester? Can they go into pre-renal kidney injury?
Yes.
Yes, that's possible because you have severe loss of fluid here because you have no aldosterone. So that would make excreting potassium really difficult because remember, which organ eliminates 80% of the body's potassium?
Kidney.
The kidneys.
Kidneys.
So the
Yeah.
20%, right? So the other 20% excretion is divided between the skin and the GI tract. And that's not enough because that's only 20%. So we still depend on the kidneys in order to eliminate it. Since the kidneys could potentially not work here, so we need to, instead of
Yes.
excreting potassium, we may be happy and content with shifting it just to keep our patient alive. So this would be your number one option, insulin with dextrose. Another intervention similar to this one is giving calcium chloride, calcium carbonate, but it's not mentioned here, so screw that. We'll just stick with insulin with dextrose. Please do not separate them. They have to be given together.
Okay.
It's not a choice between give insulin or dextrose. They have to be given together because remember, this patient also has hypoglycemia already. So if you give insulin, what will happen?
It will shift the glucose
The
into the cell.
potassium down.
Okay. And then along with that, yeah, it will drop glucose, and then we just finished also DKA. Remember DKA HHS patients? We gave them
Yeah, to bring
potassium,
the
right?
potassium.
Right, because we were giving the patient IV insulin, so the potassium will drop. So here, so because our potassium is high, so that's why this is an option. So we give insulin with dextrose, but again, be aware of the blood sugar because it's already low here. That means you have to give them together.
Okay.
And this one will take 2 hours to work. This is SPS, sodium polystyrene sulfate. It's given by mouth or via an enema. It takes 2 hours to work. So that won't be any help for us in the immediate time. So if your hyperkalemia is severe, you have to give this one first. This one would be number 1. If let's say I have all these ordered, right? So doctor writes all these 1, 2, 3, 4, 5, 6, 7 orders on hyperkalemia management. Which one would you carry out first?
the heart rate,
Monitor the heart rate.
All right.
blood pressure.
On telemetry first. And then you give this one, this would be my second choice. And then this one,
Third choice.
right, I would give this one. Be careful again, because we're giving diuretics. However, blood pressure is already low. So if you give this as a choice, do so once your blood pressure is already stable, right? So just use common sense if you're asked to, let's say, prioritize which one to give first. And this one, discontinue any spironolactone, potassium restrictions, so no bananas, oranges. Intake and output, very important, because we had a drug alert in chapter 64, remember, in DKA management. What do we monitor before giving never mind, because we're not giving potassium here. We're restricting potassium. So never mind.
Professor,
Yes, go ahead.
can you tell me the order again? The monitor the heart rate rhythm. What's the second thing you would do?
It's about always consider patient safety. So even if you give this will take a few minutes, about 20 minutes, as you saw in chapter 64. You learned that this thing works in about 20-30 minutes. So between that 20 to 30 minutes, what if the patient goes into cardiac arrest? How would you know?
Okay.
All right, so
Okay.
you need to know by putting them on a monitor. That way, if they go down quickly, at least you can call rapid response until these guys here work. So this one should work in 20-30 minutes, dropping your potassium level. And then this one will kick in 2 hours later. Because remember, this thing here, is this a permanent fix for hyperkalemia?
No, it's temporary.
It is temporary. So after 4 hours, that potassium will go back into the bloodstream. It'll leave the cell again because the insulin's gone. So by that time, this here should work. Okay, by that time, the patient's already having bowel movements, so they're losing potassium already. And that's it. There's nothing really that we can, well, we can try to prevent it, but that they came in with trauma, you're already there. So these are the other causes besides the three we mentioned, which are trauma, surgery, and infection. So these are the other causes of adrenal insufficiency.
Professor,
Huh?
is there any antidote if the person we administer insulin and then if the patient goes to cardiac arrest, is there any, before doing any treatment, is there any antidote for that?
Antidote for which one?
For the potassium, if it went too low.
Well, you give potassium.
Oh, okay. So
Yeah,
we put it back again. Oh.
Yeah, there's really no magic when you can't win with potassium. You can't win. There's no, you don't store it anywhere.
Okay. All right. Thank you.
Like fat, I have plenty of it. No, I'll never be, that'll never be a problem for me.
Okay, because some medications we have like antidote, so I thought.
No.
Okay.
Potassium. Okay. Remember in pharmacology or elsewhere, you were told that when you're taking steroids, you have to taper it. Yeah.
Yes.
Yeah, that's what you've been taught to teach your patient, right? Never stop it abruptly. It has to be tapered. You take a medrol dose pack, you have to follow it, right? The dosing decreases, right? Over the 7 to 10 days or 2 weeks. So this is the reason. Doing so, because we never really taught the patient, why do I have to do that? Why do I have to taper the steroid? This is your reason. It will cause acute adrenal insufficiency. You will go into hypotension, hyperkalemia, and hypoglycemia. So this is the reason. Others are hypophysiectomy, which is treatment for the other problem, which is hyperpituitarism, meaning you have a tumor in your pituitary gland, causing an increase in the pituitary hormones, leading to the opposite problem of adrenal insufficiency, which is now Cushing's disease. So the patient will need surgery. Plus the tumor, how big is your pituitary gland?
It's small, it's not big.
Size
Pea
of a pea, right? Pea size is the description. So the tumor, will the tumor be smaller or necessarily bigger than the pea?
Can be bigger than
Bigger.
It's always bigger.
Yeah.
So therefore, when you remove the tumor, you end up removing the adrenal gland.
Pituitary.
Yeah, it's almost impossible to leave it in because the tumor is already around it, and you can't remove the tumor without damaging the pituitary gland anyway. So you're better off just taking the whole thing off. So therefore, you have no more pituitary gland. So you'll have to replace all the hormones that it's supposed to release. And when you have that, then you have Addison's disease already. So that's why this falls under a secondary cause of Addison's disease. Make sense? Okay, so that's the pituitary. However, this is adrenal insufficiency. There's nothing wrong with the adrenal gland here, but because the pituitary gland controls the adrenal gland, that's why anything that affects the pituitary gland affects all other glands controlled by the pituitary gland. Any question on that?
No.
Okay, so I'll get back to that thought later when we get to thyroid problems, because thyroid problems can be primary or secondary as well, meaning you can have hypothyroid either caused by a thyroid disorder or a pituitary disorder. Are you with me so far?
Yes.
Meaning, yeah, because it can be primary or secondary, because remember the endocrine glands are all controlled by the pituitary gland, right? So meaning in order for them to work, they depend on the pituitary gland to tell them what to do. So you lose the master gland, all the other glands become useless. Does that make sense?
Yes.
Okay, so just hold that thought for now. So we'll do it when we get to the thyroid disorders. So these are the other causes of adrenal insufficiency. So this one, not affecting the pituitary. Pituitary is intact here. You have other disorders affecting the adrenal glands themselves, the ones sitting on top of the kidneys. So these here are pituitary problems. Or you can also say that's why they're called secondary or indirect causes, because they are not adrenal problems. These are pituitary problems, but because the pituitary again controls the adrenal glands along with all other endocrine glands, that's why it still leads to adrenal insufficiency. So this part here now is not the crisis anymore. We're done with the crisis. Crisis was managed over here. So here, beginning here from the assessment to the interventions, these are now for Addison's disease, not the crisis, okay? So day to day, the patient still has low sugar, salt, and sex hormones. And as far as the sex hormones go, they were mentioned here. I'll just mention them because again, they're not life-threatening, but they do matter with the female patient. So these are what the patients will look like. So they'll have decreased body, axillary, and pubic hair. Not that it's not, beneficial sometimes, because that gives you, you don't have to wax, but you do have other sexual characteristics changes as well, because your hormones are low. So you may not look as female as you're supposed to look. Does that make sense? Okay, I hope you get the picture.
Yeah.
All right. Yeah, you say yeah because you don't care, right?
Doesn't look good.
All right, so here in the females, for instance, they'll have menstrual changes. Not, again, not that that's a necessarily a bad thing. Menstruation isn't very, when I don't think women are really looking forward to those, but it is a good sign, right? At least that, you don't have to be, that you're menstruating, so there's no baby coming. But for men, this is a big, I would say life-threatening condition. Impotence is quite serious. You will lose the will to live, okay, if you have that. Other signs and symptoms, again, related to low aldosterone, low cortisol, and low sex hormones. So here are your key features, chart 62-7. This will also include hyponatremia and hyperkalemia symptoms as well, because to some degree the patient will have those. Probably not as serious as during the crisis, okay, but here are the problems. So we have hypotension, hyponatremia, hyperkalemia. Potassium and calcium always go together. So if one is low, the other is also low. They always go together, potassium and calcium. Because this part here, the increased pigmentation has something to do about the melanocyte stimulating hormone here, because they're controlled by the same hormone. So if the adrenal hormones are low, the melanocyte stimulating hormone tends to be also low. Oh, no, sorry, elevated. Sorry, it's the opposite. So it
Elevated?
to be elevated. So that leads to the bronze pigmentation, increased pigmentation of the skin. Diagnostics, I'm not testing because there's a test here called the ACTH stimulation test. We don't typically take part on this test. Nursing wise, they just order it and they draw the blood, and then that's as far as our roles go. We don't really take part, so I'm not testing that. I am testing the results. Okay, so sodium will be decreased, potassium will be high, glucose will be decreased, sodium, calcium high along with potassium. Okay, so these are all Addison's disease here. Cortisol, this is your sugar hormone, decreased. Now, when we go to Cushing's later, I'll go back to this chart, compare it now. So they're all totally opposite. Because in Cushing's, when you had low sugar, salt, and sex hormones in Addison's, you have a high level of salt, sugar, and salt hormones here in Cushing's. However, the treatment for Cushing's involves either removal of the adrenal glands, one or both, or adrenal hypophysectomy. So in either case, the patient, after treating this, will end up having Addison's disease. So same pattern. And vice versa, actually, since we're replacing the hormones here, because you don't have salt, sugar, and salt hormones, correct? You might end up giving too much, wherein you'll develop this problem here now. I'm just giving you a heads up when we get to the interventions. So this is the pattern of all endocrine problems. You start with one. During treatment, you may end up developing the other problem, and then vice versa. During treatment of this, you may end up with this one. You okay with that?
Yes, but it's very hard to manage, right?
Well, there's nothing we can do with endocrine.
Mhm.
As far as imaging, this is just to see, remember the causes here are tumors. Okay, so they'll do the CAT scan or MRI to see the tumor, and then they'll do surgery. Hold on a minute, I think I forgot something. Because we have the hypophyseectomy and then we forgot to do the post-op care.
Mm.
Okay. Right here, sorry. Okay, go back up. So after this is above the acute adrenal deficiency, because the interventions for Cushing's later will involve hypophyseectomy. So let's say you have a tumor, right, causing the disorder. So the patient will now undergo surgical removal of the pituitary gland. So there are two ways they do this. They can either do open craniotomy, so they'll drill a hole in your skull, open it, and then remove the tumor that way. That is not frequently done because the tumor can be removed because we're going toward minimal invasive procedures now. So the technique most commonly used is called the transsphenoidal. So they'll go through your nose. So they put small instruments through your nose. Of course, you're under general anesthesia for this. So they'll drill a hole, remove the sphenoid bone, go through the sinuses, and then reach the pituitary gland. And they remove the tumor. Little by little, they break it up and then take it out one piece at a time. Post-op, which is now your responsibility, this is how you do it. Regardless if they do a open craniotomy or a transsphenoidal hypophyseectomy, it's brain surgery nonetheless. You messed with the patient's brain, you removed something there, so it is brain surgery. So post-op care will involve, of course, watching for increased intracranial pressure. So you monitor the patient's neuro status. And why do we do this again? Why do we look for fluid, especially for output greater than intake? What did we just conclude before the break?
Diabetes insipidus.
Okay, do you remember that one of the causes was brain surgery or brain trauma? All right, so this patient might develop diabetes insipidus post-op. Although we do deep breathing exercises, remember the surgery is through the nose, so there will be some bleeding. It may not be possible to breathe through the nose though, because there will be a dressing in it. Unlike most post-op patients wherein we tell them, we encourage them to cough, blow the nose, or sneeze, we don't do that with brain surgery or any patient with brain trauma or stroke, because that increases intracranial pressure. The part here where you are prevented or restricted from brushing your teeth is they also have an incision at the floor, at the roof of your mouth. They make an incision there, so you might injure you might injure the incision, okay, and then cause bleeding. So you can only do flossing and oral mouth rinses until told to do so. Typically, that's around 10 days. That's usually the limit when you have any mucous membrane surgery. Remember in tonsillectomy, you remember that in pediatrics? How long is the risk for bleeding in after tonsillectomy? Textbook says about 10 days, right? 7 to 10 days. So it'll be the same here. So there is an incision again on the roof of the mouth to reach the pituitary gland. So you don't want to mess with that incision for about 10 days. So let's just say 2 weeks. Other activities that increase intracranial pressure besides coughing, sneezing, or blowing your nose are bending at the waist, or others are sexual intercourse also causes increased ICP. Singing, okay, so if you're singing or using wind instruments, you're a jazz player, you know, you play the sax. What else? Any condition that causes you to hold your breath, pretty much, which you're doing a lot during sexual intercourse, while playing a saxophone, while singing, right? So, or bending over. Okay, so that is also you're holding your breath before that, or lifting something heavy. So these are all conditions, or even coughing, right? You can't cough unless you took a breath, right? You take a breath first and then hold it and then you cough, or sneeze. You can't sneeze at the end of a exhalation, right? This is impossible. So you have to have air in your lungs in order to do all these activities. So since holding your breath, inhaling and holding your breath squeezes the heart, therefore it decreases venous return, meaning blood drainage from the head is decreased when you hold your breath. So that's why all these conditions are restricted, okay, and must be avoided. Same thing here, constipation. When you're straining, you're still holding your breath. You can't push that turd out without putting air in your lungs first and then pushing. Any question on these? Hello?
No, Professor.
No, Professor.
Okay, so let's continue now. So we did the post-op care. Let's continue with we're done with the signs and symptoms of low salt, sugar, and sex hormones. We discussed why there is hyperpigmentation, and here are your problems: hyperkalemia, hypercalcemia, and hyponatremia, and hypotension. I told you to do the labs. Okay. We'll come back to this when we get to Cushing's, which is easy again. They're all totally opposite from Addison's. And I told you already, we'll skip this test because we don't really participate in that. The physician does it. Interventions now. So just think of the management you did for acute adrenal insufficiency, I mean the adrenal crisis, however, in milder forms. Okay, so this one is not really an emergency situation. We still give the same therapy, but not in large amounts. Okay, we're not really aggressive because this is day-to-day management. So here are your drug therapy, because again, the adrenal glands are not producing enough aldosterone, cortisol, and sex hormones, but the management here are only addressing the aldosterone and cortisol. At least, you know, not, well, these patients may receive some hormones, you know, female hormones eventually, but we're really concerned with the life-threatening part, which is managing sodium and potassium levels. Okay, so we replace the hormones. Here's cortisone, that's your glucocorticoid, and then your mineralocorticoid is the hydrocortisone. So this is now your replacement for aldosterone. Because this is a drug chart, so the testable part is always your responsibilities. Here, what do you teach the patient? What should you do before giving? What should you monitor for, right? So you know what to study. As already indicated, the treatment for one leads to the other. So since you're giving hormones, you may end up getting too much. By so doing, the patient will now have the other problem, wherein instead of having a deficiency of your salt, sugar, and sex hormones, now you have too much now. However, we call it Cushing's syndrome because this condition is caused by the treatment of another condition. Unlike Cushing's disease, because Cushing's disease is a primary, so that's the main difference between the two. Cushing's disease is a primary problem of the adrenal gland, causing it to increase production of the aldosterone and cortisol. However, Cushing syndrome, it's called Cushing syndrome if it's not caused by a adrenal problem. It's caused by treatment or another disorder. Meaning, Addison's disease isn't the only condition receiving steroids. We're talking about lupus patients here, rheumatoid arthritis patients, patients who've received solid organ transplants, okay, or asthma patients, COPD. Those patients are treated with steroids or any other autoimmune disorders. They're given steroids to suppress the immune system. Because they're still they're taking steroids, they might develop Cushing's syndrome as well. Are you with me so far?
Yeah, so it's like a secondary, right? Not like a
Cushing syndrome is secondary. Cushing's disease is primary.
primary. Okay.
But we'll discuss that shortly. And that's it. Any question? Please read this one. It's italicized, so that's very important. Questions? Okay, let's go to the opposite now. So this is a Cushing's disease. So Cushing's disease is the primary. The main difference again between the two is how they develop. Cushing's disease is a primary problem of either the adrenal glands or the pituitary gland. Cushing's syndrome is always secondary to a treatment, usually a treatment, hormone replacement for another problem. So here we have the opposite. Instead of having less, now we have too much salt, too much sugar, too much sex hormones. So now we have, let's take it one by one. So let's start with aldosterone. Now you have so much aldosterone. What happens to your sodium level?
Sodium level low.
It increases.
It will increase. What happens to your potassium level?
Jesus.
Decrease.
Decreases.
So that's for aldosterone. Now let's go to, we're not finished yet. So that's for the electrolytes. What happens to your blood volume, fluid volume? Because you have so much aldosterone.
So fluid volume will be increased.
Increase. So will you have fluid overload?
Yes.
Will you have edema?
Maybe, maybe not.
Maybe edema. You said maybe or maybe not, right?
Well, you have a lot of aldosterone.
Oh.
So you're retaining a lot of sodium, a lot of water.
That with sodium you would have edema.
Yeah, because this is now sodium and water, not like SiADH, right?
Oh,
So
yes,
this
yes.
is both sodium and water now. So of course, yes, you will have edema. So is the picture making sense so far? Why the patient looks like this? Okay, we're not done yet. So this is now explaining the water retention here. Now let's explain the fat deposit. The other hormone that's high is cortisol. What will happen to your blood sugar when you have too much cortisol?
Increases.
It's increase.
What will the body normally do when you have too much sugar? What will the body do to the excess sugar? Store it as
fat.
As fat. So now the body will deposit it anywhere it can. So back of the head, back of the neck, sorry, in the shoulders and in the trunk. Okay, so now you have abdominal or truncal obesity now. These are all as a result of the excess sugar turned into lipids. And okay, so now because you have more fat compared to muscle, what happens to your muscles now?
Muscles becomes loose, I think.
So you will start losing muscle mass, muscle
Yeah.
strength, because of the stretching of your skin, because of all that fatty deposits. It will stretch your skin thin. And because what's the relationship of potassium and sodium again here? Because what happens to your potassium and calcium, sorry. So our sodium is high. So what happens to potassium?
It goes high
Potassium
too.
is decrease.
What happens to potassium again?
Potassium decrease.
Decrease because sodium is high, right?
Right.
Because
Yeah.
our aldosterone is high. So
Mhm.
now what did we say about calcium
They go
Mm.
together,
and
so it
potassium? They
decreases.
go together.
Yes.
So what happens if your potassium and calcium now is low?
Calcium is low here.
So you have decreased bone density. So this
And
patient is not only at risk for skin tears because of the stretching of the skin, they will also be at risk for fractures.
fracture.
So safety is a concern here. So be careful when handling their skin when transferring them to bed because they will be very weak because there's loss of muscle mass here. So they'll have decreased strength plus add the weakened bones there because of the low calcium. So these patients are prone to injury regardless, no matter how you look at it. And because they have high stress hormones, which is cortisol, what happens to your immune response?
Decreases.
Low.
Decreases.
You are weakened, you are
Low immune.
suppressed, at risk for infection. So these are the problems, the life-threatening problems that the Cushing's patients face. Plus, on top of the subtle changes, that results. So here they become pretty much sterile because you have decreased uh, hor- um, uh, what is this? Yeah, so I mean, you can't, it'll be hard for you because you'll have menstrual changes as well, the same as in Addison's disease. So you have oligomenorrhea. So it may lead to inability to conceive. But I think conceptions would be the best, I mean, the last thing you'll be thinking about when you have this disorder, right? You'll have hirsutism. So that might also contribute to, not having a baby because, I don't want to say anything. Um, all right, so here are our causes. So we have primary or Cushing's disease, either an adrenal or a pituitary problem, as already stated. So it's called Cushing syndrome if it's caused by treatment. Okay, a consequence of the treatment for other disorders. Since all of these conditions here receive steroids, they will lead to Cushing syndrome.
Mm.
Signs and symptoms we already discussed. Please read them on your own. I won't repeat it. I already described it based on the bone and the pathophysiology. Interventions now. Right here. Oh, non-physical assessment. The psychosocial, they do have emotional instability at the same time. Lab tests. So go back here on the chart comparing Addison's and Cushing's, chart 62-8. So here we have the opposite. So we have high sodium, low potassium, low calcium. Glucose will be high. Cortisol, of course, high. And the rest are related to, all opposite of Addison. So instead of hypotension, they have hypertension. They will have these easy bruising because of the skin stretching. They'll have striae or stretch marks all across their skin, especially around the trunk, right here, stretch marks. Cardiac changes will be because of the electrolyte imbalances, the hypokalemia and the hyponatremia. And we already mentioned the increased risk for infection. That's from your reduced lymphocyte count, again, because of the inflammation caused by the high levels of stress hormone. Okay, a goal. It's possible to regain your appearance, okay? Because how the patient had those physical changes was because of the hormones, right? The too much hormones. So it can be to some extent, okay, not 100% back to your normal appearance, but at a normal or for some people just an acceptable level. Okay, better than nothing, better than what it was before. Okay, you can cure it, especially if it's the Cushing's disease. You can cure Cushing's disease because look at the causes of Cushing's disease. It's a tumor, right? So a tumor cancer of either the adrenal gland or the pituitary gland. So you remove it, you can cure it. However, like I said earlier, once you remove the pituitary or the adrenal gland, what do you have now? Because there's no more organ, no more gland to produce the hormone. What do you develop?
The opposite.
The Addison's disease. Okay, but at least you cured the Cushing's disease. However, Cushing syndrome, can you cure it?
Yes.
How? You stop taking steroids for the asthma, stop taking steroids for the organ transplant, or stop it because of your allergies. We can't say the same for syndrome because here you can't have the patient choose, right? Either have Cushing syndrome or you die from asthma. Which you want?
One.
Right? So not necessarily. So there's no cure really for Cushing syndrome. Cushing disease, yes, there's a cure. But you cure one thing, what do you have as a consequence?
The other one.
The other problem. Okay. But for Cushing's, it's not really, there's really no option. All we can do for Cushing's is just to adjust the hormone levels. Maybe ask the doctor to change the doses, okay, so that we don't have the manifestations of Cushing's. You know, we maybe decrease the dosing, but that's not that easy to do either. So it requires a lot of trial and error, but it can be possible. So here's the key features, which we already discussed, and as well as the other changes. Let's go now to intervention. Intervention is, there's drug therapy, but look at the other consequences though. So because of the fluid overload, this patient may go into heart failure and then have pulmonary edema and die. They may also have hypertensive stroke, okay, hypertensive crisis because of the severe hypertension. They may have problems with hypokalemia, not to mention the fractures and the skin tears, okay, so they're prone to injury. There's drug therapy, but look at what the purpose of drug therapy. It's stated right here. Look at the first statement. Thank you for reading, Miss Beja. Sorry, I don't know how to get rid of these. Oh, how did I do that? Miss Verona? Or Miss Williams? Maybe she stepped out for a minute. Brittany, are you here?
My speaker is a little bit messed up.
Oh, okay. What
My
about,
speaker is a little bit messed up. Can you?
that's fine. What about Miss Brianna?
Yes, Professor.
Thank you for volunteering to read.
You want me to read the whole paragraph?
Just the ones I highlighted.
Okay. Drug therapy involves the use of drugs that interfere with all right, how do you say this word?
ACTH.
Yes, ACTH, production or adrenal hormone synthesis for temporary relief.
Okay, what's the key word there?
Temporary?
Temporary relief. So will the patient be on drug therapy for the rest of their life?
No.
No.
So is it worth it to test it? Now let's skip the drug therapy because really you won't see these patients on drug therapy for long. Usually we put them on drug therapy just for temporary relief of the symptoms. The patient, of course, do you want temporary relief or you want permanent?
Permanent.
Of course you want permanent. So the only permanent relief really is to have surgery. So we will end up removing these patients, either adrenal glands, 1 or 2, depending on the problem, or the pituitary gland. Other interventions are supported. Here, let's finish them. So nutrition, because they have high sodium, what will be the diet? Sodium nutrition, obviously. All right. Here, safety, because we don't want any injuries. Fluid retention has to be monitored, so daily weights. You already know the reason. Surgery. All right, so we're planning for surgery. What will happen again after they have surgery? Because now we're removing 1 or both adrenal glands. What could they develop again after surgery?
Addison's.
And you remember the first part of the chapter? When an Addison's disease undergoes surgery, trauma, infection, what will happen?
Oh, it exaggerates it?
Acute adrenal crisis, right? So we will prepare for that scenario because remember, this patient was already used to having high levels of the 3 hormones. They are used to having high salt, sugar, and sex hormones. So we have to prepare because now, especially if we remove both, you can remove 1, but it really depends on the cost. If the tumor is involving both adrenal glands, then both will have to go. If it's only 1, even if you removed 1, the body will need time to adjust because now you have only 1 gland remaining to supply the demand, right? So either way, the patient will have Addison's disease after surgery. If both glands are removed, they will have Addison's disease forever. If only 1 gland is removed, they may have Addison's disease for about a couple years. Okay, temporary. Okay, so let's start. How do we prepare the patient for surgery, knowing that this patient may die on the operating table from acute adrenal crisis? So somebody read this. How do we prepare them? What do we give them before surgery?
Glucocorticoid preparations are given before surgery. The patient continues to receive glucocorticoids during surgery to prevent adrenal crisis because the removal of the tumor results in a sudden drop in cortisol levels. Before surgery, discuss the needs for long-term therapy.
All right, very good. So here we have, like I said, the patient is already, the body is already used to having high levels of the 3 hormones. So now all of a sudden we were going to cut that off. So they have to be receiving the steroids before, during, and a little bit after surgery. No, not actually a little bit. forever after surgery, because now the glands are gone, so you have to replace it for life. As I already mentioned, if only one is removed, then does the patient have Addison's? If only
Yes.
one gland is removed?
Temporarily, they will.
Temporary.
Temporarily, right. So
Yes.
therefore, your hormone replacement will be temporary as well for usually, I think they said 2 years right here. So if it's a unilateral adrenalectomy, then hormone replacement will only be for about 2 years. If it's bilateral, then they have to get it forever.
So, Professor, if it's only temporary adrenal Addison disease, which hormone is removed? Is that adrenal gland?
Yeah, we're talking about adrenalectomy here.
Oh.
Yeah. So depends really on how many you remove. If it's one, the patient will only have to take the hormone replacement for about 2 years. If it's both, then lifelong replacement.
Okay.
And because these patients are at risk for shock, hyperkalemia, and hypoglycemia from acute adrenal insufficiency. So you already learned that earlier. So that's what you monitor and prepare for post-op. And this part here is the continuation, by the way. This is still Cushing's, okay? This is still interventions for Cushing's. So we mentioned the pathologic fractures, because of the increased gastric acid production, these patients do develop, you already know that, right? They'll develop peptic ulcers, they could bleed, and you already know about the hypocalcemia because of the hypokalemia. Another reason is when you have high hydrochloric acid or stomach acids, that will also prevent the absorption of calcium, leading to or making your osteoporosis even worse. And they realize that, so that's why you give the H2 receptor blockers or even PPIs. And you teach them about this because this will not help with your osteoporosis and GI bleeding also. And observe neutropenic precautions. These patients are at risk for for infections. And yeah, so because they're at risk for infections, then watch these for signs. And then skincare, because again, they're at risk for skin tears and prevent falls. Now the infection here will be anything. Okay? It could be respiratory, could be a flu, could be pneumonia, could be a UTI. Because remember, their blood glucose is high. So there could be sugar in the urine, making them prone to urinary tract infections. And we already know their risk for acute adrenal insufficiency. And that's it. Oh, teaching, because there were two charts here. 62.9 we already discussed, which were the Solucortef, the glucocorticoids. Here is this is similar to 62-9. This one is just how to take the drugs. So 62.9 gave you the drugs, what they'll be taking after the surgery, or for Cushing's disease. I mean, after having surgery, because now you're replacing the hormones, correct? Under Addison's. So this is now how to take it. So instructions are, if you're taking hormones, if it's 2 doses, then the second dose must be early evening. You don't give that at bedtime. Why not? Why not at bedtime?
Doesn't it have to follow the normal secretion of it?
Exactly. Because our cortisol secretion, normal cortisol secretion, is highest in the day, and then it tapers down toward the evening. So if you take it in the evening, then you won't be able to sleep. You'll be up and about all night. Steroids should always be taken with meals. And again, what could develop? Can this patient who was in Cushing's disease or syndrome, no, Cushing's disease because we did surgery, now in Addison's, can they potentially develop Cushing's syndrome now?
Yes.
Yes.
Yes, that makes
Yep.
sense.
So it goes around and around. Okay. So the poor patient with Cushing's disease wanted to end it all. Okay, let's do surgery. So she had surgery. Now she has Addison's disease.
Yes,
And now she has to take the hormones, which, if she's not careful, she could develop Cushing's syndrome. And now she finds herself back in the same problem. But at least now it wasn't Cushing's disease. This is now Cushing's syndrome. I don't know if that's any better, but
Why you laughing, Professor?
no. Yeah, sorry. Steroids. So why do we again not stop? What was the consequence? If you remember sick day rules in diabetes. So the patient with diabetes was told to never stop the insulin, right? Because they could go into DKA or HHS. So here in this patient who is taking steroids for life, can they get sick also while taking steroids?
Yes.
Absolutely, they're at risk for infection. Now, once they get sick and now they can't take anything by mouth, including their hormones, what could happen if they can't take the hormones? What was that highlighted sentence I said earlier? I showed you earlier? What could result if this patient who's been taking these hormones for a long time suddenly stops because they can't take anything by mouth?
Adrenal crisis.
Acute adrenal crisis, which is life-threatening. So if they're sick, so this is the same, consider this a sick day rule. If they cannot take their PO hormones for 24 to 36 hours, what should they do? Call their doctor because now they need to get it parenterally, either IM or sub-Q, or go to the hospital to get them. The patient will also need to notify their provider if they're in increased stress, whether physical or emotional, because that will require them to be needing higher doses of the hormones, because they're stress hormones after all. Or better yet, teach them how to give themselves an IM hydrocortisone. So if they get sick, at least they won't go to adrenal crisis. And you still have energy, right? I can finish up 62. There's just two more, and then we're done with 62.
Can I ask you a quick question?
Yes, sir.
So if a patient has a bilateral adrenalectomy, so we know that they can replace the hormones, they can replace cortisol, androgens, corticoids, but what about the catecholamines in the medulla? Epinephrine and norepinephrine.
No. This is yeah, good, very good question. It's the adrenal cortex that is removed. It's not the entire adrenal gland.
Oh, so they only remove the cortex and an adrenal.
Because that's what's affected in Cushing's.
Oh, all right, that makes sense.
Okay. Thank you, though. Very good question. Okay, let's go now to hyperaldosteronism. This is very quick. This one and pheochromocytoma is very quick because they have the same problems. And it's pretty simple. This one, hyperaldosteronism. This is their only problem, though. Unlike Cushing's, wherein you have both sugar and salt hormones, this one is only affecting aldosterone. So this is called Conn syndrome. So what does aldosterone do again?
reabsorb sodium and water in the tubules.
Okay, so therefore, if you have a high level of aldosterone, what will be the patient's main problem?
Fluid retention, fluid overload,
And
too much salt in
hypernatremia.
yeah, hyponatremia, hyperkalemia, and what happens to blood pressure here?
blood pressure is high.
Very high. So these are the problem right here. Patient has hypernatremia, like you said, but don't forget hypokalemia. And because the sodium retention causes high blood pressure, now they're at risk for strokes, heart attacks, and acute kidney injury. Because the blood pressure here is really high now, if you remember in chapter 36, are there manifestations of hypertension? Does hypertension normally have signs and symptoms?
Oh, no.
No.
No, right? There's no signs and symptoms, but these patients do because the blood pressure here is in the 200s. In all my practice, I've only seen one patient. He was in Woodhull Hospital. He was young. He was in his 30s. He had Conn syndrome, and he was textbook. Everything you see here, you can literally open the book in front of this patient, and that's what he has. So you look at his labs showed high sodium, low potassium, and when you ask him about symptoms, yeah, he says, yeah, I got a headache. I'm tired. I don't have any strength. Okay? So this patient has all these symptoms. It was fascinating to see because you don't really see this condition very often. Of course, it's fascinating for you, but not for the patient. The as stated here, the only treatment is surgery. So we remove adrenal glands. But until then, though, because it's not that simple, we can't just say, oh, let's do surgery, let's remove it. You have to manage the patient because all the while they have extremely high blood pressure, so you have to manage hypertension. Spironolactone can be used because they do have hypokalemia. So this is helpful because it decreases blood pressure while fixing the potassium level. And that's it. Pheochromocytoma, last one for today. This is a catecholamine producing tumor of the medulla. So the tumor is in the medulla. So unlike the cortex, wherein you have the aldosterone and the cortisol, this one is in the medulla. So it's not secreting cortisol and aldosterone. This one's secreting only epinephrine and norepinephrine. So think about yourselves. If you have high levels of epinephrine and norepinephrine, what would you look like?
Jacked up.
Like irritated, irritable.
Right, and of course your blood pressure will also be very high, and you'll be like the most, you look like a Tasmanian devil, if you know Tas. So these are your signs and symptoms. Okay, and then imagine having that constantly. So it's not a pretty picture.
No.
So we treat the patient symptomatically because again, the intervention, guess what? Surgery again. So we have to remove that tumor just like in Conn syndrome. But until then, you have to manage the blood pressure, the patient's symptoms. Okay, so the hyperactivity, the jitteriness, okay, all these here must be managed. And please read the drug therapy. So they're involving multi-drugs. So not only for blood pressure, but also for the nausea. So symptomatic treatment because they have high blood pressure. So it causes nausea, vomiting. So you have the interventions here. And that's it. Until then, you manage again. Hypertension is your main management. And you teach them to avoid other causes of hypertension or things that will exacerbate the condition. So no smoking, avoid coffee. And that's the end. All right, so we'll finish chapter 62, 63, sorry. Next week, they will be